Tidelands Health. Better health begins here. It's time for Better Health Radio, brought to you by Tidelands Health. Here's Bill Klaproth.
Neck pain is less common than lower back pain, but still many experience neck pain, which can be debilitating and quite serious, sometimes requiring surgery. Here to tell us about cervical disc replacement surgery is Dr. T. Scott Ellison, a physician at Tidelands Health with a specialty in spinal surgery. Dr. Ellison, thank you so much for being on with us. Most people get the occasional stiff neck, but what are the symptoms that signal something serious is going on?
Well, it's very common for people in the middle age, below and older than middle age, to have neck problems. And typically, neck pain is due to a muscle strain and improves spontaneously within a few days or a few weeks with conservative care. So, however, some people have bone spurs in their neck, what we call spondylosis, or what the lay public would term arthritis, or they can have a disc herniation in their neck, and the result of that is agonizing and persistent headache, usually in the back of the neck and the back of the head. And many times these individuals will have radiating pain that goes from their shoulder blade all the way down one or both arms to the hand, fingertip areas, with pain and or numbness and tingling.
So you mentioned conservative care, taking aspirin, standing under a hot shower potentially, or is it ice pack? I get that confused. If you have a muscle spasm, is it ice pack or is it heat?
Typically for an acute onset of a problem, we typically use ice or cold pack, not necessarily ice. But cold is a very, very good enemy, so to speak, of pain. It's a great analgesic. It's one of the best that we have, actually. However, some people feel better with heat and massage, and quite frankly, it comes down to somewhat of individual preference. In an acute injury such as an ankle sprain, we typically are going to start off with cold or ice, cold pack. But for a neck injury, it's not unusual that I let physical therapists and give them the green light to try heat or cold, and many people prefer one or the other, and there's no preponderance, and there's no right answer. I just tell people to try what feels better, and typically people fall right in the middle of half the people tend to like cold, and half the people tend to like heat.
Well, that's good to know. Like I said, I always get confused what is proper, but I guess it comes down to an individual and what feels right to them, and I guess eventually what works then. So that's conservative care for those of us that wake up with the occasional stiff neck, like you said. So then headache, radiating arm pain, etc. Can you talk about that? So the next step is I've had a stiff neck for what? Maybe when is it time to go to the doctor? Like a couple of weeks, it's really a persistent problem. Does that signal it's time to go to the doctor then and have it checked out?
That depends on the patient's baseline of function and how it affects their activities of daily living. But anywhere between 1, 2, 3, 4, 6 weeks with persistence of pain, many individuals will present to their primary care physician, or they can present to me, either one, which is fine. And it's appropriate typically to start investigating and trying to treat this for persistence of pain, usually over a few weeks or so.
And how do you diagnose that? Is that an MRI, or can you do that just by touch and feel and going through range of motion? How do you typically diagnose more severe neck issues?
Depending on the scenario, if there has been an acute traumatic event, such as a car wreck or a fall, of course, we would typically immediately perform necessary imaging, such as an MRI or CT scan, to rule out any type of bony, nerve, or ligamentous injury. However, in the absence of trauma, typically the first place we start is with a good history, actually, and let the patients talk to and let them know what's wrong. And typically, by the history, you're fairly accurate in what you're going to find. Then subsequently, we do a physical exam. And based on those findings, and depending on the length of time of the discomfort, we may recommend someone going to physical therapy and trying an anti-inflammatory, or depending on the severity of the dysfunction, we may recommend proceeding with an MRI scan. Many people in our society have had cardiac pacemakers or placed, or they have stents, or they have some type of device in their system that they cannot undergo MRI testing, and the next best test after that would be a CT scan.
Okay, and then what do you look for? When is surgery necessary then?
Typically, surgery is a consideration when a patient fails 6 weeks of conservative care and the pain is progressive. And most notably, if they tend to have a motor deficit, if they have a particular motor group or muscle group that is weak, that correlates with the MRI findings. For instance, with a C5-6 disc herniation, an individual may have normal motor function except for weakness in their wrist, and the reflex at that level may be depressed. When you have an individual with those findings, and you have the history of the patient that matches with the physical exam and the imaging studies, then typically after having failed conservative treatment for about 6 weeks, it's reasonable to consider surgical intervention at that time, depending on the severity of dysfunction as far as it relates to the patient's activities.
So if that is the next step then, is cervical disc replacement surgery the traditional way to treat the neck issue?
No, it is not. Cervical disc replacement is a newer trend. The traditional, tried and true treatment for cervical disc pathology, whether it's a bone spur or a disc herniation, with appropriate indications for surgery, has for years been what's called an anterior cervical discectomy and fusion. We use the term ACDF, or anterior cervical discectomy and fusion. But it is a very good operation. It is usually performed through the front of the neck because it's actually less painful, and the pathology can be approached from the front of the neck instead of having to go through the back of the neck, which has a history of causing agonizing neck pain after surgery. So for many, many years, the standard of care for this type of pathology was a 1 or 2 level, sometimes more, anterior cervical discectomy and fusion, which can be performed as an outpatient. Cervical disc replacements came about and were thought about for years, and then the trials were performed in the 90s, 2000s, because one of the downfalls of the anterior cervical discectomy and fusion, the ACDF, is the fact that it causes a fused segment in the spine, in the neck. And it's a short fused segment, but what happens is you lose the motion at the affected disc, and therefore that motion energy is transferred to the disc above and below the fusion. And theoretically, at about a 25% rate over 10 years, there's a chance that the disc above and below can wear out, what we term as adjacent segment disease. And again, there's a 25% chance that at 10 years that those adjacent segments might be considered degenerative in nature to the point where they could be symptomatic as well and be considered for more surgery.
Okay,
therefore,
so now,
okay. Therefore, the cervical disc replacement was conceived, and the purpose of that is that instead of fusing that area in the neck, the surgery is essentially the same. The pathology is removed through the front of the neck. So we take out the bone spur and or disc herniations that are causing the primary problem as best we know. And then instead of placing a bone graft and a plate at that level, we put in a disc replacement device similar to a knee joint replacement or a hip joint replacement. And it's usually a little steel metal device with an intervening polyethylene structure, which helps preserve motion. And theoretically, this will decrease the chance of adjacent segment changes over multiple years, which may decrease the chance of having to have more surgery.
So hopefully it's a longer fix then.
Theoretically, we are still in long-term trials to consider this. The studies have shown very promising outcomes. There's a trend towards a decreased incidence of postoperative complications with the disc replacement, and actually there is a trend towards slightly expedited recovery times with return to work a little bit quicker than the neck fusion surgery. But let me emphasize that the gold standard treatment for this for years has been the ACDF fusion surgery. We are when the disc replacement was conceived, the clinical trials had to live up to the success rate of the fusion. That's how successful the ACDF procedure is, and it's a very good procedure for the right reasons. The disc replacement has the theoreticals, and we're still in the trials, but it is an exciting new opportunity for us to try to minimize the chance of having to have more surgery in the future.
Right. So at this time, signs are very promising for cervical disc replacement surgery.
That's correct.
So what else do we need to know about it? If someone is there and is trying to learn more about cervical disc replacement surgery, what else do they need to know about it that would help them make a decision or understand what it is?
Typically, the anterior or the disc replacement surgery would be considered in a younger patient with a disc herniation or bone spur versus an elderly patient. And the reason I say that is because elderly patients typically have more than one level of degenerative change that's probably related to their discomfort, okay? So when you have a 32-year-old with a disc herniation in their neck or a 50-year-old, and you have that individual with a one-level problem, they are a great candidate for this. And another consideration is the fact that a significant portion of our population smokes, which is a definite risk factor for less than optimal outcome for cervical fusion surgery. The good thing about the disc replacement, while we don't advocate smoking at all, is the fact that there is no fusion necessary. So that is one thing to consider when you're want to consider an ACDF surgery versus the disc replacement. The disc replacement is approved for 1 to 2 level replacement, but not more than that. And so typically what we're doing now is trying to place this in a one-level pathology problem. So your typical 68, 72-year-old who frequently comes in with a headache, like I talked earlier, of a headache in the back of their neck, their head, pain goes into their shoulder blades. They have a difficult time turning their head in traffic to drive a car. The pain goes down their arm. They can't sleep at night. It's a debilitating problem. They don't sleep. They lose their appetite. They become frustrated. Their quality of life is no good. Those people tend to have more than one level pathology, and the ACDF surgery is a great option for them. If they had one level pathology, then the disc replacement may be a consideration as well.
All right, well, that's very good information. Thank you so much for sharing with that. And if the cervical disc replacement surgery does have a longer positive outcome, I could see where someone younger, that would be a better surgery for them at that point.
That's correct. And again, the studies do show a trend towards a shorter hospital stay, although I will say that 1 and 2 level ACDF surgery and 1 or 2 level disc replacement surgery typically can be an outpatient procedure. Okay, so both can be an outpatient procedure. There is a trend towards a faster return to activity, such as work or recreation, with a cervical disc replacement. Not statistically significant, although the trend is there towards a faster recovery. And I think some of that may be due to the fact that there may be a younger patient population. So those are some things that we're looking at. And I'll say that the studies show that, at about 10 years, 20% of people with a fusion show adjacent segment degenerative changes, or where the disc is thought to wear out quicker than it should. So the rate of that happening with a fusion surgery is about 3% per year. So if you're 50 years old and you add up the statistics, the chances of having another level wear out because of the fusion is there, and it's an unavoidable circumstance in some occasions. But we do have the theoretical advantage of the disc replacement preserving motion and potentially letting us obviating the need for more surgery in the future. And it is fairly tried. I know there are some anecdotal stories of professional rugby players down in Australia that have had a disc replacement in their neck. They're actually playing rugby. That's a pretty violent sport, but I will say, too, that there are professional football players in the United States that have had ACDF surgery and actually are playing professional football as well. Both procedures are usually very good options for individuals with clearly identified cervical pathology.
Well, this is good news for somebody that's got a chronic neck problem, and it's great to see that there's more options becoming available for them. So this is just all good and positive moving forward for someone that is suffering from a debilitating neck problem. Dr. Ellison, thank you so much for your time today. Why should someone choose Tidelands Health for their spinal care needs?
Tidelands Health, we have a vibrant, transforming healthcare system. We are community friendly. We have access for the community, and I think we offer the highest quality of care in our spinal program, our orthopedic program. We have a great experience with people coming to our ER, and we have health grade statuses of 5 and multiple programs. And we are here to serve the population in our area and try to make try to help that our population be healthier, have efficient health care, a quality health care experience. And I think that's what we have to offer here, better than anyone around here at Tidelands Health.
That sounds great. Dr. Ellison, thank you so much again. For more information about Tidelands Health physicians, services, and facilities, visit tidelandshealth.org. That's tidelandshealth.org. This is Better Health Radio. I'm Bill Klaproth. Thanks for listening.